So welcome to the class. The discussion is about the diagnosis and treatment of malaria in pregnancy. This is Green Top Guideline number 54B. It is published in April 2010. The previous guideline was what we have seen was a prophylaxis or the preventive aspect of malaria. This is diagnosis and treatment of malaria. Okay, so malaria is the most important parasitic infection in humans. 75% cases are due to Plasmodium falciparum, and there are 5 to 15 deaths annually. So high-risk groups are immigrants and descendants returning to endemic areas. Okay, so they are traveling to the endemic areas and not taking the prophylaxis. They are not compliant with the prophylaxis. Prevalence of important malaria in pregnancy is not known. In sub-Saharan Africa, 25% of pregnant women in stable transmission areas have malaria at birth. Okay. No maternal deaths from malaria reported in UK last years, and under-reporting may be the reason. Okay. Now, these particular things you should know, because the question will be there on this particular thing. So there are definitions of malaria in pregnancy. So the malaria can be severe or complicated malaria, or it can be uncomplicated malaria. Now, what is severe or complicated malaria? So criteria are non-specific severe signs, exclude other causes, and there is a parasitemia can be less than 2% or more than 2% parasitic RBCs, that is a high risk. Okay, so these patients are to be treated with severe malaria protocol. So if you have a parasitized RBC more than 2%, okay, parasitized RBC more than or equal to 2%, then it is a severe malaria. If the parasitized RBCs are less than 2%, in that particular case, it is an uncomplicated malaria. So it depends upon the number of RBCs which are affected. So if it is less than 2%, we call it as an uncomplicated malaria, and it is managed as an uncomplicated malaria while it is treated with a severe malaria protocol. So these two protocols we should know. Okay, so clinically we should be able to differentiate what is the category of the malaria, and accordingly the treatment will be chosen. Okay, and third is the congenital malaria. So congenital malaria is a newborn or infant infection, and parasites are transferred in utero or at delivery. Okay, it is not transmitted by the mosquito bite and distinct from the acquired malaria. Now coming to the difference between the Plasmodium falciparum and non-falciparum. So non-falciparum will include Plasmodium vivax, ovale, malaria, and rarely novae. Okay, 75% cases are due to Plasmodium falciparum, and this is the most severe with high maternal and fetal morbidity mortality. Parasites sequester into the placenta. So this is one of the feature of this Plasmodium falciparum. It causes sequestration into the placenta, and then main adverse outcomes will be the maternal and fetal mortality, miscarriage, stillbirth, preterm birth, FGR, low birth weight, maternal and fetal anemia, interaction with HIV, and increased malaria risk. While here there is no sequestration into the placenta, traditionally considered as a benign, but evidence shows Plasmodium vivax also causes significant harm. And main adverse outcome in non-falciparum will be maternal and fetal anemia, fetal growth restriction, increasing evidence of morbidity, especially with Plasmodium vivax. Okay, and other things like a cytoadherence and rosetting is seen in Plasmodium falciparum because of the obstruction of the microcirculation to the vital organs. And response to the treatment will depend on the immunity and drug resistance, and overall risk is very high with Plasmodium falciparum. While in non-falciparum malaria, this cytoadherence and rosetting is less severe. Erythrocyte changes are seen, no placental sequestration, similar dependence on immunity and resistance. So response to the treatment will be same in both cases. It will depend upon the level of immunity and drug resistance. Overall risk is moderate but not negligible. Vivax is more harmful than previously believed. So nowadays they are thinking about Vivax also, but definitely this falciparum is the most risky. Okay. Then clinical signs, we know all: impaired consciousness, coma, multiple convulsions, prostration, respiratory distress, severe anemia, jaundice, pulmonary edema, etc. Okay. Lab findings will be high parasitemia, then severe anemia, hypoglycemia, metabolic acidosis, renal impairment, hyperbilirubinemia, hypoglycemia, coagulation abnormalities, and acute renal injury can be there. Symptoms and signs of malaria, we all know this. The same, the signs and symptoms will be there. Okay. Now coming to the diagnosis of malaria, the question can be asked on this. So microscopy is the gold standard. It identifies the species and estimates the parasitemia. So what is the gold standard? Is the microscopy. Okay. So you get thick and thin blood films. 3 negative smears if you take out at 12 to 24 hours, and if they are negative, then it rules out the malaria. Okay, so you should have 3 negative smears at 12 to 24 hours. Then rapid diagnostic test will also detect parasite antigen or enzymes, but it is less sensitive than the microscopy. And if you these tests are positive, again you have to do the microscopy only. Okay, so especially in low parasitemia and Plasmodium vivax, it is less sensitive. And positive RDT, that is rapid diagnostic test, must be confirmed with the microscopy. So the gold standard will be the microscopy, thick and thin blood films. Okay, so limitations in pregnancy: parasitemia is often lower and risk of false negative is high. Prophylaxis may suppress parasite level below the detection. Parasites may sequester in the placenta, giving negative peripheral films. Okay, so these are the limitations in pregnancy. Then clinical guidance: always prepare blood films, even if there is a delayed reading. Stop prophylaxis on admission. Check details, what drugs she has received, and was she compliant or not. If suspicion remains despite negative test, seek expert advice. And what are the prognostic factors on smear? Presence and number of tropozoites and shinzones of falciparum, and malaria pigment in more than 5% of polymorphonuclear leukocytes is the prognostic factor in cases of malaria. Okay. Then assistance for malaria blood film is mainly from 3 places in UK. One is HPA Malaria Reference Laboratory. It is situated in London. Then Hospital for Tropical Diseases at London. So Liverpool School of Tropical Medicine, it is at Liverpool. So these are the 3 places which can be contacted. Generally, the question is not asked on this. Okay. Now coming to the severity of malaria and management in pregnancy. Always assess and document severity of malaria as an aid to the management. Clinical condition, most important severity indicator, and assess promptly. Fertility rates: uncomplicated malaria, there is a very less fertility rate, 0.1%, even with falciparum. But if it is a severe malaria, non-pregnant status fertility is 15 to 20%, and it is 50% during the pregnancy. So that much fertility is there because of severe malaria, and it is less severe even with falciparum also. Okay, so mortality is 2 to 10 times higher in pregnant women. And non-falciparum malaria rarely fatal but still requires caution. So always classify the disease as a severe or uncomplicated and start the prompt treatment. Consult infectious disease specialist for severe or recurrent cases. Okay. So treatment in pregnancy: treat as a medical emergency. Hospital admission is required for uncomplicated malaria, and severe complicated malaria should be admitted into the ICU. So uncomplicated malaria will require just a hospital admission, routine admission, while severe and complicated malaria will require ICU admission. Drug of choice for severe falciparum is IV artesunate. That is the preferred. Okay. If it is not available, then quinine will be used. Okay. So treatment, remember, the drug of choice is IV artesunate. If not available, IV quinine for severe falciparum malaria. In uncomplicated falciparum or mixed infection, quinine plus clindamycin. Okay. So uncomplicated malaria, the drug of choice is a quinine plus clindamycin. Here artesunate, alternative quinine. Here quinine plus clindamycin. And non-falciparum, chloroquine is the drug of choice. Primaquine is contraindicated in pregnancy. Supportive care: don't persist with oral therapy if vomiting. Treat fever with antipyretics and screen for and treat anemia, and ensure follow-up for relapse detection. Okay. Now, drug treatment and management of malaria in pregnancy. Okay. So, what are the guidelines? So, if you have got a severe complicated malaria from any species, remember, you are clinically classifying as a severe or uncomplicated. If it is a severe or complicated for any species, your drug of choice will be IV artesunate, 2.5 milligram per kg at 0, 12, and 24 hours. It will be given after that. So first day BD dose, then daily switch to oral artesunate 2 milligram per kg plus clindamycin when stable. So in the beginning, you give 24 hours, 2.4 milligram per kg IV, followed by oral once the patient becomes stable. Oral artesunate plus clindamycin. Okay. An alternative will be to the artesunate, either you can give Riamet for 3 days, or atovaquone proguanil for 3 days, or quinine plus clindamycin for 7 days. So these are the other alternatives for the severe or complicated malaria. The drug of choice will be IV artesunate. And then severe or complicated malaria alternative. So the drug of choice here we have seen artesunate. But if this alternative, what will be the treatment? Any species, then IV quinine 20 milligram per kg loading dose. If vomiting, vomit if already, this is to be omitted if she is already receiving quinine plus mefloquine. Okay, then give 10 milligram per kg 8 hourly along with clindamycin. So first drug of choice will be artesunate. If it is not available, go for quinine 20 milligram per kg loading dose followed by 10 milligram per kg 8 hourly along with the clindamycin. Okay, so here the same is there. First artesunate followed by clindamycin plus artesunate. But if this is not available, then go for quinine plus clindamycin followed by oral quinine and oral clindamycin. These all doses you may or may not be asked, but at least drug of choice you remember. Okay. Then uncomplicated malaria, because of Plasmodium falciparum, the drug of choice is same, quinine plus clindamycin. So here whatever you have given IV, but in uncomplicated you will give oral quinine plus clindamycin, same dose. Initially you cover with IV followed by oral. The same oral becomes here as a first drug of choice in uncomplicated malaria. Okay, oral quinine 600 milligram 8 hourly plus clindamycin 450 milligram 8 hourly for 7 days. The other will be Riamet and atovaquone plus propanil. Vomiting, if it is not severe, then you can give IV quinine 8 hourly plus clindamycin 8 hourly. Switch to oral regime. So remember, severe and or complicated and uncomplicated malaria. Okay. Non-falciparum. So if you have got a non-falciparum, then oral chloroquine. This is the standard dose what we give, 600 milligram followed by 300 milligram at 6 to 8 hours and repeat on day 2 and day 3. This is the routine what we are following. Okay. So this is for non-falciparum malaria. Okay. Then relapse is known with other non-falciparum, especially Vivax and Ovel are known for relapse. And the drug of choice is a chloroquine weekly till delivery. Okay. And relapse prevention after delivery with G6PD test for primaquine can be used after the delivery. Okay. Not during the delivery. So for Ovel, 15 milligram per day for 14 days. Vivax 30 milligram per day for 14 days. And if there is a G6PD deficiency, 45 to 60 milligram weekly for 8 weeks. Okay. So this is for the relapse prevention for these particular two. This is after the delivery. Okay. So during the pregnancy, chloroquine weekly till delivery. So this is what is for prevention of relapse. Okay. So have you understood the malaria treatment? You will divide it into complicated, uncomplicated. Complicated drug of choice is a IV artesunate. Okay. Followed by IV you will give first and followed by oral artesunate plus clindamycin once the patient is stable. Okay, if alternative will be quinine plus clindamycin IV followed by oral quinine plus clindamycin. Okay, and uncomplicated will be oral quinine plus clindamycin. Is it clear? Is it clear? Okay. Then quinine and malaria treatment in pregnancy. Quinine adverse effects. So what are the adverse effects? Sometimes they can ask you about the adverse effects of quinine. 7-day course can lead to chingonism that will present as a tinnitus, headache, nausea, diarrhea, altered auditory and visual acuity. These are side effects may lead to non-compliance, which can result in treatment failure. Okay. So quinine and malaria treatment in pregnancy. Hospitalization can be useful to ensure compliance with quinine and clindamycin dosing. Allows observation and reduces risk of vomiting or rapid deterioration. Vomiting is a symptom of malaria and known adverse effect of quinine associated with anti-malaria treatment failure. Management always use antiemetic. Metoclopramide considered safe in first trimester. Repeat dose after antiemetic has taken effect. Persistent vomiting, go for IV therapy or parenteral therapy. Okay. Adjunct medication will be antipyretics, paracetamol, etc. etc. Now coming to the malaria and pregnancy and malaria treatment efficacy. Anti-malaria efficacy may appear lower in pregnancy due to reduced drug concentration. Pregnant women should be advised about the recurrence risk and follow-up. Weekly blood film screening can detect malaria early and reduce maternal death. So these patients should be kept for follow-up, weekly blood screening. Okay. Placental sequestration of Plasmodium falciparum makes efficacy assessment more difficult, and PCR confirm prolonged submicroscopic carriage and late recurrences, which are unique to pregnancy. Okay, so quinine, if she is treated with quinine, there can be recurrence up to 45 days or 12 weeks. Artesunate 98 days, and artemether lumefantrine is around 63 days, mefloquine around 121 days. So this is what is the frequency of recurrence. Weekly screening until delivery helps to detect recurrences before symptoms develop. So these patients, once treated, should be kept for screening follow-up. Then recurrence treatment. Now, if there is a recurrence, okay, then what should be the drug of choice? So cure rate will decline in recurrent infections. So if you have already given quinine, the success rate will be less. It will reduce to 61% from 77 to 61 in quinine. Mefloquine will 77 to 62. Artesunate monotherapy is effective, 84%. So cure rates are higher for primary infection than recrudescent infections. Recurrent infections may be less sensitive to same drug, and 7-day regimen with artemisinin derivatives are most effective. Okay. What is the UK and WHO guidance? It is quinine plus clindamycin. Limited options in the UK if quinine and clindamycin. So if there is a recurrence, again the quinine and clindamycin in UK they have advised. And what is the WHO regime? WHO regime is artesunate plus clindamycin. So that is what is the treatment for recurrence as per the WHO. And in UK and what is advised is quinine plus clindamycin. Okay. So management of severe malaria complications. So what are the complications that we should know? It can lead to hypoglycemia, it can lead to pulmonary edema, it can lead to severe anemia, it can lead to secondary bacterial infections, cerebral malaria, hyperpyrexia, and convulsions. Okay. So other complications such as renal failure, spontaneous bleeding, metabolic acidosis, shock. So these are the complications which can happen during the pregnancy. Severe malaria because of the severe malaria. These patients need ICU or HDU management, and we need to follow WHO guideline. Okay. So regular glucose monitoring for detection of hypoglycemia, glucose infusion. Quinine does not cause abortion or labor. Quinine can be used. Okay. Then pulmonary edema, you need to monitor these diuretics, upright position, etc. Severe anemia, monitor HB, PCV will be the treatment. So these are the various complications due to malaria which can happen, and this is what is the management. I'll give you these slides for the reading. Then obstetric management specific to malaria infection in pregnancy. Malaria in pregnancy, what obstetric complications can lead to? It can lead to preterm labor, FGR, and fetal heart rate abnormalities. So severe malaria with fetal compromise, you need to have multidisciplinary team. Stillbirth and preterm delivery best prevented by prompt and effective management. And uncomplicated malaria is not an indication for induction of labor. Remember, thromboprophylaxis usually not required because there is a thrombocytopenia, and recovery generally happens in 7 to 14 days. Placental histology and blood films, placenta cord recommended in peripartum malaria to detect congenital malaria. So if you have got a case of first thing, when there is a maternal history, you should always send the placenta for histopathology. Okay. For fetal distress is often due to hypoglycemia, and you need to correct the hypoglycemia as well as maternal temperature. Generally, it normalizes. Okay. So standard treatment is mother's life comes first. So what are the obstetric management of malaria in pregnancy? Obstetric problems will be preterm labor, FGR, fetal heart rate abnormalities. So prompt treatment, maternal stabilization, fetal monitoring is required. Severe malaria with fetal compromise, there is a fetal tachycardia, bradycardia, late decelerations. So multidisciplinary team will take a call on this CTG monitoring, and the paracetamol is safe during the pregnancy. Per se induction of labor is not required. So uncomplicated malaria is not an indication for induction of labor. Induce only if there is an obstetrical indication. Fetal distress often linked to the fever or hypoglycemia. So always exclude the hypoglycemia, especially if she is on quinine, and give tocolytics or steroids if there is no contraindication. Okay. So if there is thrombocytopenia, coagulopathy, you will stop the withhold the thromboprophylaxis. There is a PPH risk, so you need to watch carefully. Delivery method. No proven role of early cesarean for malaria. Placental and cord blood studies you have to carry out. Congenital malaria may present weeks or months after the postpartum, and if placenta or cord blood is positive, you need to monitor the infants and fever in the baby, and weekly blood film you have to do. Okay. So in the baby, you will always do the weekly blood film if the placenta or the cord blood is positive. So this can be asked as a question. Okay. Circulatory abnormalities, increase umbilical artery resistance, cerebral redistribution, etc. reflects impaired placental perfusion, and monitor pregnancy closely. Okay. Okay, so what antenatal care after recovery from malaria you will provide? Routine assessment, go for the fetal growth scan, monitor maternal hemoglobin, platelet, glucose, etc. Regular fetal growth assessment is advised. If growth restriction is detected, then go for management as per the RCOG guideline. Okay, counsel the woman about the risk of relapse and risk of FGR. Malaria in pregnancy is responsible for more than 50% FGR in endemic settings. Okay, most babies born after infection are still normal birth weight, and additional fetal surveillance not needed unless growth restriction. So once you detect the growth restriction, then go for surveillance. Otherwise, only diagnosis of malaria is not indication for the surveillance for the SGA. Okay, prevention of recurrence, effective anti-malaria treatment, follow up with prophylaxis. Recurrence risk is low after effective treatment. If symptoms recur, prompt screening with malaria blood film at specialist hospital is essential. Post-malaria care considerations. Again, these are not asked, so there is no question. So I'll skip this particular slide. So what is the risk of vertical transmission of malaria and infection to the baby? Vertical transmission from mother to fetus is known to occur. Risk is higher if malaria is present at the time of birth. Risk increases when the placenta and cord blood are parasite positive. This is the most important thing which you should remember. So all neonates born to mothers with malaria in pregnancy should be screened at birth with thick and thin blood films, undergo weekly screening for 28 days to detect delayed infection. So what is indicated is a screening at birth with thick and thin blood films, and the same screening weekly till 28 days is recommended. So additional details: transmission occurs when parasites cross the placenta during pregnancy or birth. And in non-endemic countries, congenital malaria is diagnosed if parasites are found in the neonate without travel to the endemic areas. Reported prevalence of congenital malaria is 8 to 83%, and largest case series is from US. Plasmodium vivax is the most common species in congenital malaria. Okay, primaquine often used unnecessarily in neonates. Placental positivity warrants weekly monitoring for of the infant for 28 days. This is the thing which you should remember. Okay, so this finishes the second topic of malaria also. Thank you.